Hello everyone, I am Dr. Bhatia, Director of DBMCI. So today I'll be talking to you regarding treatment of hypertension. And as you are well aware that nowadays that old-timer one-liner questions are all obsolete. The concept that just read this guide and that guide, that is all obsolete. Now the exam pattern is totally going toward the integrated approach. Okay, so today I'll be integrating all these subjects which are relevant to the treatment of hypertension. But before that, I had a question for you. A 20-year-old male patient who is a known case of Pheochromocytoma is a question from surgery, okay, was operated to remove the tumor. What will happen to his BP soon after surgery? BP will rise, BP will remain as before, BP will fall, or any of the above can happen. All of you write down in your copy your answer A, B, C, D. Right? So many of you have joined RAAS just now. I give 1 minute so that you can think, you can write your answer for those who just joined right now. Right? So I hope all of you must have written the answer right. In the meantime, if you want to ask me a question, you can very well post, you can chat box. I'll be too happy to reply to your question. Okay. Well, I'm so happy people have answered like anything. I'm getting, huge, almost everybody is answering, quick. I'm glad that I'm teaching the illustrious student in front of me. Great. Right. Chaliye, let us see. Yes, I'm getting so many answers. Chaliye. So before I answer this question, let's learn. Of course, this is a beautiful question from surgery. This question already have come twice in AIMS exam also. So let's learn the basic concept of pathology of pheochromocytoma, without which you will never understand the surgical aspect of the pheo. The basic concept of pheo is that, first of all, very, very important question. It is a highly vascular tumor. Now, the clinical applied of this statement. The CA stands for clinical applied. What is the clinical applied? Okay, applied pathology. Applied pathology is, since it's a highly vascular tumor, and the one point which the question in all the exam, you never do FNAC, is never done. In this is a very frequently asked question. What is FNAC? Again, little bit of pathology. In FNAC, the full form is fine needle aspiration and cytology. What they do, they like this, the tumor. The tumor, they put a needle, they put a syringe. With syringe, there's a needle is there, and they can aspirate. This is a fine needle aspiration cytology. Any tumor, any maybe lymph node, they put a needle, they aspirate, and the content of is examined under the microscope. But here it is a highly vascular tumor. So FNAC, if you put a needle, patient will bleed to death. This is a very, very important question. Very, very important question. And this again is a important question. So we got two questions in this particular slide at the moment. Well, so we learned about highly vascular tumor is there. An ultimate treatment of pheo is surgery. Final treatment is surgery. And before that, what medical treatment give, that I'll talk soon when I'm discussing the treatment. So ultimate, what I told you is a treatment is surgery. Well, what will we remove the tumor and block. They remove the tumor and block. And block means the total tumor is removed. Suppose this tumor is there, and here is the normal content of the where. So they remove and block. They remove total. They remove this They don't cut it. They remove as it is. Why? Why they will not cut? Because if they cut, the bleeding will happen very fast. Now we have done the surgery. Well, what will happen to the surgery after BP? Well, after BP will happen, the BP will fall. BP will fall soon after surgery. This is again a very commonly asked question. That means the answer to the question what I asked to you is the BP will fall. This is the answer. But why this is the answer? This you will never know unless we know the basic concept about physiology. So let's talk about basic concept about physiology. Physiology of hypertension. Now, again, very important question from physiology. The parameters, what are the parameters on which BP depends? BP depends on which parameter? It depends on three parameters: cardiac output, COP is cardiac output, peripheral resistance, PR is peripheral resistance, and third is blood volume. Blood volume. Very, very important question. So there are three parameters on which the BP depends, right? Physiological parameter, of course. Now, whenever the BP will rise, whenever the BP in the body will tend to rise, body will try to control the BP by its natural way. Body will try to control BP in its own natural way. But body doesn't have a very effective method to control cardiac output. Body doesn't have a very effective method to control peripheral resistance. But body can very well control blood volume. By what mechanism? By diuresis, by the kidneys. Again, an important question for you. What do you mean by this? BP is rising. Now, well, we all know in Pheochromocytoma, BP is high. BP high because of what? Catecholamine. So, due to catecholamine, the BP is high in Pheochromocytoma, right? So, the BP remain almost always high. So, in these patients, constant diuresis keep on happening. Now, what is the clinical applied? The clinical applied of this situation is that in these patients or patients of Pheochromocytoma, which are a case of chronic hypertension, they have a reduced intravascular volume. This is the clinical applied. They have a reduced intravascular volume because of what? Constant diuresis to countercheck the hypertension. So, in fact, the second clinical applied, they are clinically dehydrated. One more clinical applied of Pheo, due to same reason, they have an increased hematocrit. Hematocrit is high. Why? Because they are dehydrated. There are three important clinical applied of this particular statement. Now the fourth applied, surgical, now applied surgery. So when the surgical aspect, when we treat, when you remove the source of catecholamine, that means you have done surgery, you have removed the source of catecholamine. Body is already dehydrated. The BP will fall drastically. BP falls drastically. Now I tell you what happened actually in operation theatre. When the surgeon is operating for Pheochromocytoma, when he is about to cut the tumor, he will ask the anesthetist, be ready. Anesthetist is ready and he will infuse immediately. The moment the tumor is cut, he will infuse large amount of normal saline. NaCl is normal saline. Immediately they rush very fast. Otherwise, if you don't do, the BP will fall drastically and that can lead to any problem. So friends, now you can nicely correlate your physiology with surgery also, with pathophysiology also, with pathology also, what has happened. So this is all about the question what I asked to you. So you are clear about it. A quick recap of what I taught you so far. BP is depend on three parameters: cardiac output, peripheral resistance, and blood volume. And pheochromocytoma is a highly vascular tumor, and we never do FNAC. This is what we have learned so far. After that, one more question again, a beautiful question from biochemistry in relation to pheochromocytoma. Let's learn more about pheochromocytoma. We all know pheochromocytoma is a tumor of chromophene cell. Chromophene cells. We also know that this tumor can arise in the adrenal medulla. And they can also arise outside extra adrenal medulla also. That means they can arise in the adrenal medulla, or they can arise outside the adrenal medulla. And now come the rank number one getting question is this, and one point which is known to 70% students know about it, that adrenal medulla secrete epinephrine and norepinephrine both. Adrenal medulla secrete epinephrine and norepinephrine both. Extra adrenal medulla, that means any tumor which arises outside the adrenal medulla, that secrete only norepinephrine. And now come the gold medal, rank number one getting question is this. What is the reason? Why? What is the biochemical base of the reason that extra adrenal tumor, any tumor which is outside adrenal tumor, does not secrete epinephrine? Gold medal question is this. You can answer this question. Okay. Quickly, what is the reason? Okay, I got answer from Abhimanyu. Good, very good. Yeah, I got answer from Robin Singh also, Amit also. Yes, you are right. Well, the answer is for that. To know, let's learn the biochemistry. Let's learn the basic concept about biochemistry. Okay, so we all know that catecholamine are synthesized from tyrosine, and this tyrosine is converted into dopa. This dopa is converted into dopamine, and this dopamine is converted into norepinephrine. Up to this step, it can occur in any of the chromophene cell. Now, norepinephrine is converted to epinephrine by N-methyl transferase. Norepinephrine is converted into epinephrine by an N-methyl transferase. Now, the question from biochemistry, very frequently asked question. This N-methyl transferase, it is there only in adrenal medulla. In adrenal medulla only. It is not there outside the adrenal medulla. So that's why epinephrine can be formed in adrenal medulla. Since it is not there outside the adrenal medulla, so the epinephrine synthesis doesn't happen. The right answer is N-methyl transferase. I'm seeing so many people have answered. So many people. I'm really happy to teach such illustrious students. Thank you very much for answering the question. Good. So we learned, we could nicely correlate with your biochemistry also to why epinephrine is not there outside the adrenal medulla. So we are clear about it, right? So with this background of till now we just learned about the answer the question was there. So now we talk more about management of hypertension. Okay, how to manage a case? One thing is there. Whenever you are being asked a question on management of hypertension, maybe in your pharmacology exam also, if you are in second year, whichever year you are, if they talk about hypertension management, your first thing should be lifestyle modification. In your theory exam also the question comes, you should write lifestyle modification. This examiner should be able to see it. Now what do you mean? Of course there are many parameters, but I'll speak to what is most important you should remember. In the lifestyle modification, you ask the patient is hypertensive. You ask, of course, you ask him to control his BP. You ask him to control his diabetes, DM. If he is diabetic, ask him to control diabetes. Third, you ask him to stop smoking if he is smoker. And after that, you ask him to control his lipid level also if lipid level are high. This is a very, very important question. This question from PSM, preventive and social medicine also. What are the importance of these four things? Well, these four are high BP, increased BP, diabetes, smoking, and high lipid, hyperlipidemia, diabetes and hypertension. There are all the four, the clinical applied, they are the four major risk factors for CAD. So it's essential that the patient should be advised to take care of this, very, very important. In addition to that, you also ask the patient to control the body weight. Okay, this is a single most important parameter. If the person loses the body weight by 10 kg, the BP may fall around 4 to 8 millimeter of mercury per 10 kg body weight. So this very frequently, again, this is one point not known to most of students. Out of all these, exercise, diet, salt, etc., the single most important which really help in reducing the maximum BP is weight. 10 kg loss of weight can fall 4 to 8 millimeter of mercury. Again, a very, very important point. This is especially in relation to diet, salt, exercise, and body weight. They are the usual four options they are given. The best answer is body weight. Frequently asked questions there. Okay, with this background, so we learn lifestyle modification. So now we have to treat the case. Patient of hypertension has come to us. How to treat? Now we talk about drug therapy. But again, we have done the PSM part, that we ask the patient to contain the lifestyle. Now, in the management, we start the pharmacology treatment also. But before that, again, we got to learn the basic concept about physiology. We need to know more about basic concept about physiology. BP, so here you can write down physiology. Okay. In the physiology basic concept, BP is cardiac output multiplied by peripheral resistance. Okay. Then the cardiac output is equal to heart rate multiplied by stroke volume. It means what? BP is equal to heart rate multiplied by stroke volume. Heart rate, stroke volume multiplied by peripheral resistance. Friends, if you know this formula, you can answer any question on hypertension in whichever exam you write. This is the key summary. The BP is heart rate, stroke volume, and peripheral resistance. This is a basic concept about the physiology. With this background, now we move on to pharmacology. Let us see which are the drugs which are going to control heart rate. So we will take each one of them, and each parameter will see which drugs they are going to control. So beta heart rate is being controlled by pharmacology. First is beta blocker. This is known to everyone. Beta blockers, like example, are like metoprolol. So beta blocker, they control the heart rate, that is known to all of you. But one question which will be surely coming to you in your exam, the one more drug which has recently been launched is ivabradine. Ivabradine. So this is a new drug which control heart rate. So it reduces heart rate. Got it? Just like beta blocker. But this is much better drug in controlling heart rate. Why? Again, the clinical applied. The clinical applied of this is that it has effect on, number one, it has effect only on heart rate. It only reduces heart rate. It has no other major systemic effect. No other major systemic effect. It means what? We can very well give in asthma. We can very well give this drug in peripheral arterial disease. PAD stands for peripheral arterial disease. We can very well give in erectile dysfunction. ED stands for erectile dysfunction. So there are n number of side effects of beta blockers, because beta blocker can induce asthma, they can induce peripheral arterial disease, they can lead to erectile dysfunction, etc. All other side effects which are done by the beta blocker. So that's why we cannot give this in such disease. So, but in ivabradine we can give very well. So this is a beautiful clinical applied that it has got only effect is bradycardia, and we can very safely give in any other systemic disease where the beta blocker are contraindicated. So this was regarding pharmacology. I hope you understood. Now we correlate with the medicine clinical side also. So in the clinical side, so what are the conditions? Now we come to medicine side. We written physiology, we written pharmacology. Just below that only you write medicine. Okay, what are the conditions? The clinical medicine, clinical science, where we'll be using beta blocker. So beta blocker we will be using in coronary artery disease. Why? What is the basic? Again, basic concept, clinical applied. In coronary artery disease like angina, like in angina, we want to reduce heart rate. What's the reason? What's the clinical applied? Number two, why you want to control heart rate in a case of angina or maybe MI? Because more the heart rate means more oxygen consumption. More and more oxygen will be consumed, the heart rate is high. So the next clinical applied number. So we want to reduce heart rate. Reduce heart rate will lead to what? Reduce oxygen consumption. So that's why we want to give a drug. That's why we give beta blocker in a case of coronary artery disease. CAD is coronary artery disease that include angina and myocardial infarction. So we got lovely clinical applied regarding angina, and we can control the heart rate. Good. Now we also use beta blocker. We also use beta blocker in case of hyperthyroid. We also use in hyperthyroid to control high BP. Now come the question, again the clinical applied question. Which beta blocker you would like to use in a case of hyperthyroid? Give me the answer. Which beta blocker you would like to use? Quickly. In hyperthyroid. Abhimanyu has answered. Health Brody, Rishi, Sukhbir, all have answered correctly. Yes, the right answer is propranolol. Propranolol. Why? Why you want to use this drug? Again, the clinical applied. Because it is a beta blocker. Yes, we really want to reduce the heart rate. That's one reason. But there is one more reason, that this propranolol inhibits T4 into T3 conversion. T3 is the active hormone. All the manifestation of hyperthyroid are due to T3. So once we use propranolol, this inhibit T4 into T3 conversion. So that's why the effect of hyperthyroid will also be reduced. So propranolol has two use. One is to reduce the heart rate, and other is to reduce the peripheral conversion. It's again a very frequently asked question in endocrine. So friends, we learned about heart rate. A quick recap of heart rate control. We use beta blocker and ivabradine. And ivabradine has advantage only control heart rate. It got no systemic side effect. And in medicine, we use beta blocker in CAD to reduce the heart rate, and we use in hyperthyroid, where particularly we use propranolol. This is what we have learned so far. Now we move on to the second parameter, that is stroke volume, right? So let's talk more physiology about stroke volume. So stroke volume physiology, and after that we'll correlate with pharma and medicine also. So SV stands for stroke volume. Point number 1, and diastolic volume of each ventricle. And the diastolic volume of each ventricle is about you can say 100 to 120 ml. Little variation is there, but for easy calculation, I am taking 120 ml. It is somewhere around 90 to 120, but again for easy calculation, I am writing 120. And the end systolic volume is about 60 to 80. Again for easy calculation, I am taking 80. It means at the end of systole, at the end of systole will be about 40 ml. With the end of this thing, about stroke volume, 80 ml goes out. It is about 30 to 40 ml. 30 to 40 ml remain in the systole, and about 80 ml goes out. This is about 40 I am taking. Take a skip of tongue. So at the end of systole, about 80 ml goes out and 40 ml remain in the systole, and that means with each stroke about 80 ml goes out. This is known as stroke volume. So if I have to tell you the value of what the definition of stroke volume, it is the amount of blood coming out from each ventricle in each stroke. Is stroke volume. The amount of blood coming out of each ventricle in each stroke is stroke volume. It is about 80 ml. Normally it is 60 to 80 ml. But for easy calculation, I am writing 80 ml. Now, the end diastolic volume was 120 and 80 ml has come out. So out of 120, 80 ml has come out. This is known as ejection fraction. 66.6% is the ejection fraction. And a very commonly asked question, normal ejection fraction is somewhere 50 to 70%. Even some books have written 175 also. But by and large, some variation is there in majority of the book. but I am taking the average what is given. So about in this our calculation we got 66.6% is the ejection fraction, and one of the easiest way to check ejection fraction is echocardiography. Echocardiography is the best easiest bedside method to control ejection fraction is echocardiography. This was the basic physiology of stroke volume. With this background, we come back. So we have learned the physiology of stroke volume. Now we come to pharmacology. What are the drugs? What are the drugs which are going to reduce stroke volume? Answer is again beta blocker. Point to be noted, beta blocker reduce heart rate. Beta blocker, they reduce the stroke volume also because they reduce the pumping action of the myocardium. They reduce pumping action of the myocardium. And what is this known as? It is negative ionotropic drug. Ionotropic drug. So anything which reduces the pumping action of the myocardium, we call as negative ionotropic drug. So now you understood. That's why the clinical applied. That's why they are contraindicated in congestive heart failure, right? And they reduce the heart rate also. What is that known as? That is known as negative chronotropic effect. Chronotropic effect. This is the most often students get confused in these two terms. So that's why I have deliberately written at the same time negative ionotropic and negative chronotropic so that you don't get confused. So I hope negative ionotropic means reduce pumping action of the myocardium, and negative chronotropic means they reduce the heart rate. With this background, so beta blocker, they are contraindicated in congestive heart failure. I am sure now somebody is going to ask me, sir, nowadays, in some cases of heart failure, we give beta blocker. Yes, we give. But that I'll take when I take congestive heart failure, then I'll explain to you which beta blocker are given and why and when. But as of now, because I got limited time, I have to just stick to treatment of hypertension, right? So as of now, beta blocker are contraindicated in congestive heart failure, but repeating second time. But the latest concept that we give beta blocker, only few beta blocker and only in certain special situation of congestive heart failure. Now second drug which reduce this stroke volume is nitrates. Okay. Now the clinical applied. First of all, now what is the mechanism of action of nitrate? They are peripheral venodilator. Question from pharmacology. Venodilator. They dilate the peripheral veins. So now what happened? As the peripheral veins are dilated, okay, and we also know that veins they are, what are they? The physiology, they are capacitance vessel. Capacitance vessels. So the whole blood is pulled into peripheral tissues. Blood pulled into peripheral veins. The whole blood goes to the veins in the periphery. So the clinical applied number 4, it reduces venous return to the heart. They reduce the venous return to the heart. It means they reduce the preload. This is the most important line. What is preload? The preload is, that means whatever the amount of blood coming to the right side of the right atrium is preload. So here the whole blood is pulled into peripheral tissues. So less return of the blood will come to, the preload will be reduced. Now the clinical applied. More clinical applied. The more clinical applied is that, what are the clinical condition where we use in relation to hypertension? We use the clinical applied. We use this in hypertension with coronary artery disease. We use with hypertension with CAD. We use hypertension with congestive heart failure. We use hypertension with coronary artery disease, with congestive heart failure, and we also use in hypertensive emergencies. We also use in hypertensive emergency also. They are the clinical applied. Okay, remember it. It is a drug that we use in hypertensive emergencies also. So a quick recap about nitrate. What are the main mechanism of action? They are venodilator. What happened to blood? It's pulled into peripheral tissue. It leads to what? Reduce venous return. It will lead to what? Reduce preload. Where are the condition where we use hypertension with coronary artery disease, hypertension with congestive heart failure, and hypertension emergency we use. This is about nitrates. Now the third drug which again going to reduce stroke volume is diuretics. Diuretic is the third drug which we are going to use to reduce stroke volume. So where we use clinical applied, we use in hypertension with congestive heart failure. Now come the gold medal question. What is its role? What is its role in hypertensive emergency? I want anybody should answer this question. What is the role of this diuretic in hypertensive emergencies? Write down quickly. Okay. What is the role of diuretic in hypertensive emergencies? Quickly. Yeah, I'm getting answers. Good. Shivam, Amit, Robin, very good. I'm so happy. Now it has got this is the rank number 1 getting question. Well, as far as diuretic concerned, if patient has only hypertension without congestive heart failure, they are contraindicated. They should not be given. Why? We just read the basic physiology. The body in a patient who comes with a hypertensive emergency, he is already dehydrated because the kidneys have already done the diuresis. So we don't give diuresis in hypertensive emergency. But the patient has hypertension with congestive heart failure, then this can be given. So a quick recap. The primary use of diuretics is especially if the patient has associated congestive heart failure. We can give in essential hypertension also, but definitely we never give in hypertensive emergencies without congestive heart failure because body is already dehydrated. But if the patient has hypertension with CHF, we give this drug also. So friends, a quick recap of the 3 drugs we got which are going to control stroke volume. One is by beta blocker, other is by nitrate, and third one is diuretic. Now we come to the third category. Third parameter that we have to control is peripheral resistance. So let's learn let's learn about basic physiology of peripheral resistance. Basic concept about the peripheral resistance. Peripheral resistance. Physiology first. Physiology. Physiology, first question. What is the primary site of peripheral resistance in the entire circulation? Site of peripheral resistance is arterioles. They are the primary site of peripheral resistance. So now let's learn about anatomy of the arteriole also. This is the arteriole. In the arteriole we have a alpha receptors. We have a beta receptors. Alpha receptor are vasoconstriction. They are vasoconstriction. And beta are vasodilator. Alpha receptor are vasoconstrictor, beta are the vasodilator. So we have a beta receptor and we have a alpha receptors. Alpha receptor and the beta receptor. Vasodilator, vasoconstrictor. Third point, we still continue with physiology. Now peripheral resistance is 1 by R4. R is the radius of the arteriole. Radius of the arteriole. So that means narrower the arteriole, manifold will rise the peripheral resistance. This again itself is a very frequently asked question. So narrower is the arteriole, more dilatate, more will the peripheral resistance will go very high. So it means now if we give now the clinical applied, if we give alpha blocker, so alpha blocker will block this receptor. So this will lead to unopposed beta action. Unopposed beta action. And beta are what? They are vasodilator. They are VD. VD is vaso. They are vasodilator. So the clinical applied, when we give alpha blocker, there is unopposed action of the beta action, and with beta action there will be vasodilatation. Vasodilatation means peripheral resistance will come down, and the peripheral resistance come down, BP will come down. So this is a nice correlation between physiology and medicine, how alpha blocker are going to reduce the BP. But if you give beta blocker alone, especially in Pheochromocytoma, if you give beta blocker in Pheochromocytoma in particular, they are going to block the beta action blocker, and there will be unopposed alpha action. The unopposed alpha action will lead to increased BP. Hence the clinical applied, with now we correlate with the medicine side also, pharmacology, physiology correlation. So in a Pheochromocytoma, we always give first, we give alpha blocker. After that we can give beta blocker. In Pheochromocytoma, we never give beta blocker alone. If you give beta blocker alone, the BP will rise further. Or we can give a drug having both alpha and beta blocking action. Tell me any drug you know of which have got both alpha and beta blocking action. Tell me quickly. Okay? Tell me any drug which has got both alpha and beta blocking action. Sachin has answered, very good, very prompt. The answer is, of course, labetalol. Labetalol is the best answer that we can give for having both alpha and beta blocking action. With this background of physiology, now we learn to the pharmacology. What are the drugs? What are the drugs which are going to reduce the peripheral resistance? The drugs which are going to reduce peripheral resistance are, number one, alpha blockers. As I just mentioned just now, example is prazosin. Prazosin. We especially use this drug in elderly male. Why in elderly male? Because they help in control of BP, but they also help in to reduce the obstruction due to benign prostatic hypertrophy. We all know very well that when we use alpha blocker in benign prostatic hypertrophy, it help in urine outflow. Alpha blocker we can also use in chronic renal failure. The other condition where alpha blocker are very useful is chronic renal failure. Now, second drug which is going to reduce the peripheral resistance is calcium channel blockers. The classical drug that we use in calcium channel blocker for anti-hypertensive is nifedipine. Nifedipine acts on the peripheral arteriole, it dilates the arterioles. To clinically apply it, where we use this drug, we can use in chronic renal failure with hypertension. We have a drug, again very important drug, the clinical applied. We have a drug nimodipine. Nimodipine we use in subarachnoid hemorrhage. SAI stands for subarachnoid hemorrhage. Nimodipine we use. Okay. We can use nifedipine in peripheral arterial disease. We can use in peripheral arterial disease with hypertension. It's very effective drug for peripheral arterial disease. But the main side effect of this drug are side effect of nifedipine are it can lead to ankle edema. It can lead to ankle edema, and they are contraindicated in hypertensive emergencies. They are contraindicated in hypertensive emergency. This is not known to around 60% students are not aware. Why? One more side effect of this drug is other than ankle edema, they lead to tachycardia. Nifedipine can lead to tachycardia. So tachycardia occurs. It can precipitate. So it can precipitate coronary artery. It can precipitate myocardial infarction. Since they can suddenly increase in heart rate there, and they can precipitate coronary artery disease. A quick recap: nifedipine is a calcium channel blocker, ankle edema, dilate the peripheral arterioles. Side effect is tachycardia, so they are contraindicated in hypertensive emergencies. So we discussed second drug is calcium channel blocker. Third drug which can reduce peripheral resistance is ACE inhibitor, ACEI. Okay. The third drug which can reduce peripheral resistance is AC, angiotensin converting enzyme inhibitors. ACEI, the third category of drug which can reduce peripheral resistance. So, but before that, let's learn the biochemistry of what happened in what happened when this angiotensin converting system activated. So friends, we have a liver. In the liver, angiotensinogen is synthesized. This again not known to most of students. Angiotensinogen come from the liver, and in the kidney we have a juxtaglomerular cells. It is juxtaglomerular cell which produce renin. Ultimately, renin come from juxtaglomerular apparatus, and angiotensinogen come from the liver. Now this renin will convert angiotensinogen into angiotensin 1 by the renin. Now this 1 is converted into angiotensin 2 via ACEI, so-called angiotensin converting enzyme. Angiotensin converting enzyme. So this is angiotensin 2 is made by ACEI. Now this angiotensin 2, it is a very powerful vasoconstrictor. It is a very powerful vasoconstrictor. So now I don't need to talk to this illustrious student in front of me that the angiotensin 2, which is a powerful vasoconstrictor, can increase peripheral resistance and can increase the blood pressure. This is the biochemistry of how this angiotensin 2 is made, which is a very powerful vasoconstrictor. A quick recap. Angiotensin come from which organ? Liver. Renin come from which place? Juxtaglomerular apparatus. Which renin converts what? It converts angiotensin into angiotensin 1. Angiotensin 1 is converted into angiotensin 2 by what? ACE. And angiotensin 2 is what is the physiological effect? It is a very powerful vasoconstrictor, and thereby it will increase blood pressure. Now when we use ACEI, so let's learn now we correlate our biochemistry with pharmacology also. So biochemistry we just learned what are the steps. Now let us see. So when we use L-chirin is a renin inhibitor. So if I have to go back to this slide, L-chirin will act at this step. L-chirin pharmacology, it is a renin inhibitor. So that's why if renin is not acting, so it will not, angiotensin will not be converted. After that we talk about ACEI, which are enalapril, lisinopril. They are ACEI. Okay, if I go back to same slide, so they will be acting at this step. They will be inhibiting ACE. So all the prils, lisinopril, enalapril, they are ACEI. Then we have angiotensin receptor blocking drug, sartan. They are angiotensin receptor blocking drug, ARB. Angiotensin receptor blocking drug are the one. Okay. So they are going to block the receptor. So it will angiotensin 2 will not be able to act on the receptor. So it will prevent the vasoconstriction. Now certain gold medal question. Which ARB is given with fat, which is useful in gout? Which ARB is useful in migraine also? Which ARB act on the PPAR gamma receptor also? Which ARB act on the PPAR gamma receptor also? These are the gold medal question. Okay. For gout, we use losartan. For migraine, we use candesartan. For PPAR gamma receptor, we use telmisartan. These are the rank number 1 getting questions there. They are the gold medal getting questions there. Now the side effect. Dry cough is the most common side effect. But angioneurotic edema is the most dangerous side effect. Angioneurotic edema is the most dangerous. And one more thing, they can lead to hyperkalemia. So that's why they are contraindicated in chronic renal failure. We all know very well in chronic renal failure, already hyperkalemia is there. So we never use ACI in hyperkalemia or CRF. And one more important is contraindication is OBG. In pregnancy, it is absolutely contraindicated. This question comes in all the exams throughout the world every year. The one drug which is contraindicated in pregnancy is ACEI. They lead to fetal wasting. So this is about ACEI. So now we learned about as far as peripheral vasodilator, we learned about alpha blocker, calcium blocker, ACI. And now the fourth category of drug which are going to reduce peripheral resistance are direct vasodilators. They include hydralazine. It is a drug of choice in pregnancy with hypertension. Side effect, it can lead to SLE-like features. It can produce SLE-like features. Second drug, which is again causes direct peripheral vasodilator, is alpha-methyl-dopa. Alpha-methyl-dopa, again a drug of choice in pregnancy with hypertension. Side effect, it can lead to Coombs, positive hemolytic anemia. It can lead to black tongue. Also. But this is very, very important question. So in pregnancy, we can use hydralazine, we can use alpha-methyl-dopa, and ACI are absolutely contraindicated in pregnancy. Now third drug, which is a direct vasodilator, is sodium nitroprusside. This is a wonderful drug to be used in hypertensive emergencies. The mechanism of action, it is a peripheral vasodilator. It is a venodilator also. Since it is a peripheral vasodilator, it will reduce peripheral resistance. Since it dilates the veins also, the whole body is pulled into veins, so it reduces preload also. This drug came about 50 years back, but still it is a wonderful drug. What is the advantage of this drug? It's very quick acting drug. It's comparatively safe drug, no major side effect. But even the best quality of this drug, now comes the rank number one question. It has got widest safety margin. In dosage. You can use from 0.5 to 8 microgram per kg. Okay. So the safest range, huge range is there, safety margin, 0.8 microgram per kg to 8 microgram per kg is the range where we can use this drug. Safe drug is this. Okay. So friends, this is all about the management of hypertension. Then with certain newer drugs which have been introduced recently. Pheneldopaim, Urapdipil is there. There again the drug, and of course aliskiren, the one more drug. Aliskiren, the drug that we use in hypertensive emergencies. We can also now other drugs that we can use in hypertensive emergencies are nitrate, labetalol, We can even use hydralazine infusion also. There are the other drugs that we use in hypertensive emergencies. There are also drugs that we use in hypertensive emergencies. So friend, this is all about management of hypertension. I had a very limited time of just 1 hour. So because as I was given instruction that I had to limit, otherwise a beautiful audience to talk. Okay, and and one more thing. If you want to see, I'm recorded a beautiful series of lectures, state-of-the-art lectures I've recorded. If any one of you want to see my videos, what you do, you send your name, we are in which year, your college name, you can send to this number, staff number. Right now, I give you a time of 1 minute, send this, and I will be sending you many more videos to see. You will really love to see, and you will really enjoy those beautiful videos. Okay, send right now. I give you 1 minute to send this thing, right? I got a question from Rajat Singh. What is the nitroprusside drip rate? This you have to regulate depending on how much is the BP. Okay, you have to control. Just all these drugs you have to control how much BP is there, and you titrate the dose accordingly. Okay, so I'm getting so many thanks. It's a lovely audience. Okay, and there's some more information my staff is giving to you. The entire team of DBMCI is committed to give you the best of the services. We are always there to help you out. Whatever we can do, entire team of DBMCI is there. And again, before I close the session, I'm sure you must have send all this information to me. I got a question from, what is the drug of choice in pregnancy in general? You can use hydralazine, you can use methyl dopa, or even you can use labetalol also. Okay, right? So I hope you all have sent to this information. We'll be sending you more videos. So, and you can very well contact me. This is my staff number. But I'm available to guide you. Anyway, this is the medicine book written by me. Is a mini Harrison. Harrison is the ultimate book, but it's a very vast book. And this mini Harrison, very popular, based on 20th edition of Harrison, ultimate book. You don't need to read anything else if you have read this book, Mini Harrison. The book is available on Amazon also. Our idea, the DBMCI want to train you in such a way like an eagle, it can fly above the sky. So we all are committed to train you in such a way this bird can survive from -45 to +45. The idea is that we will train you in such a way that you can appear for any exam to not only to pass, but to get the top rank. Our aim is, the entire DBMCI team is committed for this thing. So before I close, my staff will like to have something for you to, and I'm sure by now all of you must have sent the, yeah, my staff want to show you something. Just wait. I'll be with you. A lot of questions. 8800. I'll be very happy to reply to your question also. But as the time is limited, so I had to just restrict to time. Anyway, and I thank all on behalf of myself and on behalf of the entire DBMCI team. We all thank you for joining us and giving a chance to speak to all of you. I'm really happy. You are all illustrious students. So personally also I thank you. Personally, I also thank the entire team of DBMCI, those who have really worked hard to make this program a grand success. Although it's too late, but still my team is actively working for last so many days to make this program a grand success. So thank to you, thank to student, thank to entire team. Thank you very much. God bless you. And I hope you have sent the detail. And any question, you are more than welcome to ask me or my team. We are all there to help you out. Thank you very much. Good night.